Hello and welcome to my somewhat true story, based on a true story of Nana Has Cushing's Her Story. My name is Brady Tidwell and I'll be presenting for you today. After living a relatively active and healthy lifestyle, Nana has started to notice some changes to her body and health. She isn't sure if these changes are occurring due to her complicated knee replacement or her advancing age. After receiving poor care from urgent cares in her rural community, she presents here to establish primary care and get her health back under control. She discontinued her blood pressure medication after it quote unquote made her feel worse and claims she feels much better now. She misses performing some of her favorite household tasks such as mowing the yard. She also is having more trouble keeping up with her great grandchildren, which she has multiple of, and wants to be able to spend more time with them. She's noticed an overall health decline, and when it comes to the poorly managed care from the urgent care clinics, especially with the blood pressure medication, that will not be a focus of this presentation itself, but another story in general. Nana has had a very good medical history when it comes to a woman of her age. She is allergic to Toradol. It has caused multiple episodes of respiratory distress. She has recently gained some weight, not sure how much. She hasn't reported any falls or trauma recently. She did have surgery in 2015 for a bilateral knee arthroplasty, which ended up being complicated when the surgeon put in the wrong size in both of her knees. Um, she also has had a couple recent diagnoses of hypertension from a local nurse practitioner for her. Medication wise, she only takes used to take two medications. One of those being an unknown hypertension medication, which she discontinued herself after having adverse events from it. The other one is high dose steroid injections she gets for knee pain. These are regarding pain she's had after the complicated knee replacement. She used to get injections of Toradol and steroids, but now she's had to transition into high dose steroid injections. Lately, she's been having some worsening weakness, she said. She bruises more easily, and little cuts and scrapes she gets take longer to heal. She's been more fatigued, had less energy overall, and she's claimed to be a little more sad and having some mood swings. She spends a lot more time in the bed, and she attributes that to decreased energy and decreased mobility. She has had chronic pain that has really plagued her for quite a while now. Because of her history of corticosteroid use and a possible inclination for Cushing syndrome, one of the important things we can do as a new provider for her is to compare her physical outlook previously to now. In older pictures, as the one presented in the presentation, she has a very skinny face, especially for somebody her age, no redness, and none of the typical buffalo hump we, spoiler alert, could see here soon. So being able to compare changes in this way is very beneficial for the provider, and my grandmother's high usage of Facebook has become beneficial in this scenario. Upon physical exam, she is an 80-year-old woman, so she is in the elderly range, but she seems to be in fair health previous to what has gone on. Weight of 69.1 kilos, which is up a few pounds since what she claims is her baseline weight. But besides that, her Vital signs are unremarkable besides a slight hypertension of 134/90 in her blood pressure. She did mention a history of hypertension recently, so that is somewhat to be expected for her. Glucose was under control. And then for skin, hair, and nails, we noticed some male pattern hair growth to her lip and chin, facial flushing, some abdominal striae, and scattered contusions at various stages of healing. Nothing super concerning when it comes to the bruises, especially since she claims no trauma or falls. Um, the male pattern hair growth to the lip or chin could coincide with a possible Cushing's diagnoses, but also could be a side effect of her age and lowered estrogen level overall. Continuing on, when we do our physical exam on Nana, we do notice she has some roundedness to her posterior neck, almost a lump. For Cushing's patients, it's usually called buffalo lump or buffalo neck. Neurologically, she's intact. Cardiovascular wise, she is doing fantastic. Besides the scattered bruising, we notice respiration and respiratory system is fine. And GIGU also unremarkable. Until we get to musculoskeletal, she does have some bilateral upper extremity and lower extremity weakness. She also has the aforementioned pain. I didn't add that on here on the presentation because it technically doesn't coincide with the Cushing's case study itself. For diagnostic testing, Cushing's etiology most commonly caused by prescription of corticosteroids in supertherapeutic dosages. Since that's the most common and Nana has a history of using high-dose corticosteroid injections, it's far more likely that we can attribute the Cushing's to a medication etiology compared to a pituitary tumor, which for most people is good news. Guidelines suggest for performing laboratory tests on her over imaging studies like an MRI so we can diagnose the cause for the Cushing's before getting to that point. We'll start out with the late-night salivary cortisol test. It's a sample collected by Nana right when she's getting close to going to sleep. She'll do 2 to 3 of these collections just to lower the risk for error. If she has Cushing's, the test will pick up on the failure of her circadian cortisol nadir to regulate the cortisol at the correct level at that time frame. And when we perform this test, we expect to have a less than 1.7 nanogram per milliliter level of cortisol. Nana actually came back with a 10.54 nanogram per milliliter level. The next diagnostic testing we'll perform is a 24-hour urinary-free cortisol test. We'll expect it to come back from 10 to 100 micrograms per 24 hours of collection. Nana actually came back with 128 micrograms per 24 hours, so a little bit over that expected level. This is a test that's also collected by Nana over a 24-hour period. She'll once again repeat this 2 to 3 times, just like she did the previous test. If she has Cushing's, the increased serum cortisol will overwhelm the corticosteroid binding globulin, or CBG, be excreted into the urine. All 24-hour urine collections are very reliant upon strict adherence, either by, if it's inpatient, the nurse doing the collection, or outpatient, the patient doing the collecting, to make sure we have correct results. Nana, given her strict adhesion to medical instruction, is a great candidate. Outside of her discontinuing the blood pressure medication, but personally knowing her in this situation allows me to know the backstory to that, and that is a different animal to get into. If for some reason we cannot get sufficient results from the first two diagnostic tests, we'll move on to a dexamethasone suppression test. What we'll do here is have the patient take a milligram of dexamethasone at midnight or right before, and then present to the provider at 8 in the morning for cortisol testing. The body should start regulating the cortisol level, and if it has trouble, we can pick up on that through our testing. For medical reasons, she'd be a great candidate for this test, but it'd be really difficult on her to, at her age, wake up at midnight, take the medication, go back to sleep, and then make it back to the doctor's office by 8 in the morning since she lives out of town in a more rural area. So we're going to stick with the other two tests first and then use the dexamethasone suppression test if needed. This follows current guidelines set up by the Endocrine Society. We're not really concerned for a pituitary tumor being the cause of her Cushing's disease, even though it is possible. If we cannot get to the root of her cause of her symptoms, an MRI would be something we would consider. At this point, if you've mentioned Cushing's at all, and if the patient has any education on the subject, which my grandmother does, given that almost everyone in the family is medically is involved in the medical profession, except for her and her husband. So one of the things we'll want to do is kind of explain and educate her on what's going on. We'll talk about the possible causes and kind of reassure her that it's more than likely the high-dose corticosteroids over a tumor. At her education level when it comes to medication, she'll be very concerned for cancer or tumors and surgery itself. But we'll educate her on the fact that more than likely this will be a medication regimen change over a surgery, which should, and when it comes to the overall level of being diagnosed with the disease, help her feel at least somewhat better about going forward. Pathophysiology-wise, the endocrine organs maintain hormone levels due to regulation by the pituitary gland as a part of the hypothalamic pituitary endocrine axis. And disruption of the pituitary or the endocrine organs causes significant imbalance to this fragile yet very effective feedback loop. Up to 20% of anterior pituitary cells are corticotrophs, and tumors arising from these cells cause excessive ACTH production. Higher ACTH levels cause the adrenal cortex to produce and release abnormal amounts of cortisol. Corticosteroid binding globulin, or CBG, can't keep up with the elevated levels, leaving higher free cortisol. The resulting glucocorticoid levels elevate, leading to Cushing's syndrome. Prolonged glucocorticoid elevation stresses corticotrophs and leads to poor negative feedback and elevated cortisol. These cortisol levels in turn inhibit the release of corticotropin-releasing hormone, or CRH, and ACTH. It is important to identify and correct Cushing's before the decreased ACTH causes enough atrophy in the adrenal cortex to be irreversible. Especially in Nana's case, we'd want to correct the problem while we have a positive prognosis. In Nana's case, the prolonged released steroid injections for her knee pain were causing some deposits and leaking into the circulation at toxic levels. Since it was a prolonged release mechanism, this happened for weeks at a time. And then when she would show up for follow-up injections, they would recur. Nana has been very focused on getting back ahead of her health so she can get back to the life she likes to live. This has led her to get more injections recently, possibly causing a worsening of her overall condition. This suppresses the hypothalamic adrenal axis, and it is similar to the similar pathophysiology-wise to the tumor etiology. Um, whether a tumor sets off the pituitary balance or prescribed corticoids mimic the increased corticoid levels, you can kind of see the same presentation. So for Nana, she had multiple allergic reactions given her Toradol and low-dose steroid injections, leading to an increase in those steroid dosages for her remaining injections. Like we just mentioned, her remaining pain led her to more injections. The supratherapeutic dosages maintained elevated steroid levels for weeks and recurred to the follow-up. The increased levels continued and in turn worsened her condition overall. Um, we already had mentioned the overstimulation or overwhelming of corticosteroid binding globulin, or CBG, not being able to keep up with the elevated levels. Um, the prolonged glucocorticoid elevation stresses the corticotropes and leads to poor negative feedback and elevated cortisol, which in turn can lead the kidneys to retain sodium and water, which would explain her weight gain, especially around her trunk, face, and neck. On top of the steroids themselves having a documented history of increasing appetite, this would explain her recent change in physical in appearance. Her easily bruised, slow-healing skin and weakness are classic signs of cortisol causing protein wasting and decreasing collagen, weakening the blood vessels. These cortisol levels can also weaken bones, but thankfully, knock on wood, Nana has not suffered any fractures. The loss of collagen that we mentioned when it came to her bruising, uh, coupled with the weight gain, is why she has some newly formed abdominal striae. Um, she didn't get these when she was pregnant. It's hard for her to understand that she's had these in a small amount of weight gain, but this would explain to her why it is presented at this time. Um, the the weak blood vessels, also with the high cortisone level messing with her stress response, explains the flushed appearance she has that normally she probably has most of the time, but also highly explains why she gets it when she presents to the doctor to figure out what is wrong with her. Further on, the cortisol can cause vasoconstriction, leading to hypertension and other cardiovascular events. It also can lead to metabolic syndrome causing glucose intolerance, which her glucose had actually come back as normal, so this had not been an identifying factor for her. The adrenal androgen levels can be thrown off during the hormone axis imbalance, causing androgenic hair growth. For her at her age, it could be expected, but if the hair had shown up pretty recently, it would be it'd be an identifying factor for what is going on with her. The hypertension, she did um, have noticed at a couple provider follow-ups before she had come to us. It was mild. It was treated, like I had mentioned earlier, very poorly. What we'll hope is that if we can get her back to her normal rhythm of life, that her blood pressure will also return to normal and is just elevated simply because of the Cushing's. One problem we run into in diagnosing Cushing's and when it comes to explaining it is that most of the symptoms can be found in the general population. There's a lot of symptom overlap, and Nana's explanation of why she thinks she's been gaining weight and all these other and feeling sad in these other instances is very logical and makes sense. It's also an expected aging process, so we have to be very careful when it comes to our diagnosis so we don't take away a treatment that could be helping her. But risk factor wise, she falls right into the category. She has long-term steroid use. She's elderly, and she's a woman. These are all found more often in these populations. For tumors, the risk factors are fairly similar. You also add in age 30 to 40 when it comes to tumor growth, and family history of pituitary or adrenal tumors seems to have somewhat correlation with with Cushing's happening more often regarding a pituitary tumor. If you've had a history of benign tumors, you're also a risk factor for developing more in your adrenal gland, or the pituitary could be one of the next places. Prevention wise, we want her to limit her steroid use in the future since she doesn't have asthma or arthritis yet. We can hope that we can cut down this usage altogether. We want to monitor her for signs and symptoms of hypercortisolism after. And for tumors, I'm sorry, there's no prevention. It's just quick monitoring and treatment as fast as you can. For Nana, we're going to have to taper her off these steroids. For injections, that could be very difficult. It's hard for us to know how much is leaking into her capillaries at a time. So we'll have to have close follow-up with her, monitor any changes in signs and symptoms or her physiological status. We'll hope to, like we mentioned earlier, cessate steroid usage in the near future, and hopefully with her medical history we can. One thing we'll also do for Nana as her grandson, I wanted to do, but as a provider, you should as well, is help expedite this knee revision. This has been going on since 2015. It's time to get this woman the treatment she's always deserved. Alternatively, if we come to find out that these injections are not the cause, but it is Cushing syndrome, we'll need to identify and map out for surgery the tumor, and we'll do that using an MRI. One thing that will also happen when it comes to surgery is intraoperational consultations. This is usually done with a fellow neurosurgeon and maybe an endocrinologist and even possibly oncologist. They'll do tissue testing, MRI imaging, and kind of work together as a multidisciplinary unit since these tumors are so small and hard to get to. But successful surgery does have a remission of 60 to 80% in patients, which is fantastic. Usually they have to do glucocorticoid replacement until the hepatic pituitary axis is stable. For Nana, this won't be as much of a problem since she was supplementing, for lack of better words, the glucocorticoids. We'll monitor for recurrence of symptoms. This will go on for lifelong. We can continue to do some of the lab testing that we had done to diagnose in general, but it will also carry a risk for false positives. So one thing we can do is monitor for recurring common signs and symptoms that she's already seen. Outlook-wise, the fatality rate is quite high at 50% within 5 years, and even higher than that in some cases. But that only applies to those who were without successful treatment. Majority of people do have successful treatment, and surgery rates, like we mentioned, are 60 to 85% for all individuals, and medication-induced individuals have a high success as long as they're monitored closely while the provider adjusts their either steroid dosages or another plan of care. In conclusion, I'll give you all some happy news. Nana got a new orthopedic surgeon who revised her knee replacement, and she has been getting along fantastically. Her mobility and strength have improved significantly. In the picture shown, she does have her walker slash um, wheelchair that she uses, but she had that there because just in case she couldn't make it around for this fun day of activity, but she never got to use it. And by all the paint you see on it, it had a good time as well. She's no longer in chronic pain. Her weight returned to almost baseline. Energy and mood is significantly improved. She babysits all these grandbabies, or great grandbabies, sorry, multiple times a week. Has had no more problems with hypertension and or hypotension, which is one of the adverse events she was dealing with when on the medication. She is happy. She's mobile. She's able to mow the yard again, which is odd to say for a woman her age, but man, she just loves to do it. Um, Thank you so much for giving me your time today. I hope you learned something about Cushing syndrome. And with this hard to diagnose and often overlooked syndrome, especially in its mild cases, maybe you can catch it on somebody one day. Thank you so much.